Medical College, Ernakulam, and also the Nodal Officer for COVID-19, Government Medical College, and who is moderating today's CME with faculties Dr. Anupam Kumar, Assistant Professor of Medicine Division of Pulmonary, Assistant Professor of Medicine Division of Pulmonary and Critical Care Medicine, Michigan State University, and Dr. Sujith V. Cherian, Assistant Professor, Critical Care, Pulmonary and Sleep Medicine, University of Texas, Health McGovern Medical School, Houston, and all my senior colleagues and friends, a very warm greetings from IMA Thrissur, and welcome you all to this academic feast. As we are all in this world war against this dreaded COVID-19 pandemic, it is very important to make a strategy to improve our striking capabilities against this invisible enemy, for which we need to share our experiences from different parts of the world, and we have to defeat it at once and forever. I hope this continuing CMEs updating our knowledge will help. IMA Thrissur started this journey way back in January 28th with the first awareness class for our members inaugurated by DMO of Thrissur, Dr. KJ Reena, even before the first case appeared in India and the first IMA branch to do so. Though we never thought of such a grave situation, what is happening around now during that time. Now I invite our chief guest and state president, Dr. Abraham Varghese, for his inaugural address. Over to you, Dr. Abraham Varghese. Hello?
Yeah. Respected branch president, Dr. Joy Manjila, my own secretary of state, Dr. Gopikumar, Jain Chimmen joint secretary, Fathahudeen, the moderator for today's function, Anupam, Kumar, and Sujith V. Cherian, the speakers today, Indudharan, Unni Baby, and Dr. Devadas, Dr. Sugatan, dear friends, ladies and gentlemen. Warm greetings to you all from IMA Kerala State Branch. It gives me great pleasure to be with Thrissur Branch once again for its CME session, a special CME session, I should say, and I should congratulate Joy, Pavan, and the team for organizing such a webinar, and that to the statewide. He makes our job less, burden, because he keeps on making all sorts of activities which probably myself and Gobi, when we plan to do something, he does it early. So congratulate you, Joy, for making such programs. And as you rightly mentioned, you were the pioneers in this field. When the COVID struck, you started this CME session before the illness was detected. CME sessions are always essential feature of the practice in modern medicine. So it is basically much more than what we have, and it provides us to provide quality care for our own patients. So it is always a useful one. And we all say that it is a fight against the pandemic. When you fight, it is not with guns or the atom bomb. We are fighting with our knowledge. So sharpening our knowledge is the most important thing. I remember a story of a king who used to visit his country always. And he happened to meet a woodcutter. And he asked the woodcutter, how many trees do you cut every day? He said 10. And how many did you cut 5 days back? He said 15. And how many did you cut a month ago? He said 20. So the number was high in the beginning, and as days go by, the number was decreasing. So he asked him why. He said, I don't know, because I only can cut 10 now. So the king asked him, when did you sharpen your axe last? Then he said, about 3 months back. So before 3 months, he could cut about 30 trees, and now it has come down to 10 because there was no sharpening of the axe. So the story very clearly says now that you have to sharpen the weapon which you have got. And the only weapon which we have got is your knowledge, which you have to keep on sharpening till your death, I should say. Till you, it's not till you practice, it's till your death, because you need it every day, because you have been trained to practice modern medicine only. That's the only subject, that's the only job which you can do. So you have to sharpen your knowledge. So I'm so glad that Trichure branch is coming forward with lots of activities, not only the CME sessions, many other activities. I really congratulate you too for the excellent services you are offering to your members. I feel you deserve every credit to get a state award or a national award, because that's the way in which you are performing. So hats off to you for performing all these activities, and hope you will continue to do it for another 3 months. That's the time when we have to complete our job. So thanks for, I thank the Thrissur branch for giving all sorts of support to the state, Kerala state branch, and wish all the very best to the Thrissur branch. And let me take this opportunity to officially declare that this CME session is open and inaugurated. Thank you so much for the patient listening. Jai Hind, Jai IMA. Over to Joy.
Thank you, President Dr. Abraham Varghese, for your excellent talk. And now I invite our State Secretary, Dr. P Gopikumar, for his address. Over to you, Dr. Gopikumar.
Okay, good evening, President of IMA Thrissur branch, Dr. Joy, State President, State Joint Secretary, other state leaders, the eminent faculty, and moderator, and friends. Well, as rightly pointed out by the State President, Thrissur branch is always in the forefront in any activity related to COVID or even otherwise. Always it is like that, because very often the state takes clue from Thrissur branch, and we are doing things in line with the activities of Thrissur branch. Definitely, we are very happy, and I am much more happy and proud that I am a member of IMA Thrissur branch. Definitely, that adds to my credit anyway. As you are aware, now we are fighting the COVID, and the disease is evolving over the months, and the treatment modality is evolving. Of course, the knowledge about the disease COVID-19 is every day it is getting updated. Probably during January, February, we were not aware much about the virus, about the disease, but now we know what exactly is going on in a patient with the novel coronavirus, the disease process, and so on and so forth. So it is very, very important that every day you have to sharpen your skills, sharpen your knowledge, and update your knowledge regarding the disease. And that's what we are doing. Actually, the Kerala State branch had done a 40-topic webinar series during the last month, and July and June and July. And in between, there were enough number of CMEs. Even Thrissur branches conducted 2 or 3 AMS webinars regarding COVID on various aspects, definitely. So this process has to continue probably, because we are going to live with this virus for another maybe 1 year or 2 years, or even more. So definitely this is very, very important, and I congratulate the IMA AMS Thrissur chapter headed by Dr. Indudharan and Dr. Unni for arranging this excellent webinar with excellent eminent faculty. And I think I just understood that Anupam Kumar is son of our teacher, Professor Kumar. Kumar sir also is present, I think, in this webinar. Welcome, sir.
Yes. Marsari was there from the beginning.
Yeah, Kumar sir is
I am here, Dr.
Yeah,
Gopikumar. I am here, Abraham Varghese,
Yeah.
Dr. Kumar.
Welcome, sir. Welcome.
Okay,
Just now I saw that. Anyway, so we are
fine,
lucky.
okay.
Yeah. Good evening, sir.
Yeah.
So with this, with all praises to the IMA THRISSUR branch, the team, Dr. Joy and Dr. Pavan and Dr. Indudharan and Unni. I thank everyone for giving me this opportunity. All the very best for the CME webinar. Thank you. Jai IMA, Jai Hind.
Thank you.
Joy, can I
Oh.
take 1 minute?
Okay.
Just 1 minute.
Okay.
Thanks, Santosh Babu, for pointing it out that mistake of mine, which I should have told in the beginning. Friends, we are facing tragedies one after another. You know, we started with a pandemic COVID, then followed by the landslide, and now the plane crash, which happened yesterday evening. So many people have lost their life. It's right on our part to pay tributes to those who have lost their life. And I want just 30 seconds of prayers. Please offer for those who have lost their life, the departed souls, and for the family of bereaved family. Just 30 minutes of prayer. 30 seconds of you. Sorry. Thank you, friends. Thank you so much. Thank you. Over to Joy.
Thank you. Thank you, Dr. Gopikumar. Now I invite Dr. Jain Chimmen, State Joint Secretary and Joint Secretary for Mid-Zone, and our own member for his address. Over to you, Dr. Jain Chimmen.
Thank you, Joy, sir. As a Thrissur IMA member, I am sure all of us are very much thrilled by the words of our state president. I can see the 70 smile on Dr. Joy's face. So hopefully we should keep it up, and remaining months also we should forge ahead with all relevant ceremonies, and also we should be prepared, as President said, we should be prepared for any eventualities, because last year we know Thrissur also suffered the setbacks due to flood, and this year also we should be expecting those similar lines. And COVID is almost among us now, and I am glad that we have got two eminent speakers who have gone through the worst period of their COVID times, and hopefully this is the time when we are facing the toughest period in Kerala, and hopefully we'll be gaining knowledge how to overcome all this, because they have already gone through all their worst period, and I think they are on the recovery phase. So we have got two eminent speakers. Welcome and congratulations, Joyce, for roping in them for our members. And I congratulate the AMS chapter president and secretary, also Indu sir and also Unni, for arranging such beautiful topics. I wish all the best for today's seminar. Thank you.
Thank you, Dr. Jain Chimmen. Now, before I handing out to Dr. Indudharan, our chairman, a single word about how I reached to these people. Dr. Sunil Manjila is my own family man and a neurosurgeon. He is settled in Connecticut. He did a webinar on last month for our own CGP. He made me to get, I requested him to have some faculty from there, and he happily agreed. And that is how he reached to Anupam Kumar and Dr. Sujith V. Cherian. If Sunil is around here, a big thank you to him. Now I invite Dr. Indudharan, Association of Medical Specialties Chairman of Thrissur branch, for his address and introduction of our faculties and moderator. Over to you, Dr. Indudharan, please.
Hello. Good evening, everybody. I'm really glad that I'm given this opportunity to address you as well as introduce the speakers. Respected State President, respected State Secretary, my dear Trichure President Joy Manjila, and Secretary Pavan Madhusudanan, my associate Dr. Unni. I must say that the whole credit for conducting such wonderful webinars, this I must definitely say that it is an international webinar, getting speakers from abroad. And look at the list of participants here. Oh, great. Hats off to Joy Manjila and Pavan. It is Joy's unending surge of enthusiasm that has resulted in such a growth of Trichure IMA. Great, Dr. Joy and Dr. Pavan. Without much ado, no, I will go ahead to the task of introducing the speakers. I'm very glad that today, no, both the speakers and the moderator are alumni of Trivandrum Medical College. In fact, no, when Joy requested me to get a moderator, I was hunting for somebody from Trivandrum. And before I got somebody, Joy himself got Dr. Fathahudeen, who is also an alumni of Trivandrum Medical College. Today's first speaker is, I think it is Sujith Cherian, or is it Anupam Kumar? I think it is
Anupam Kumar. Anupam Kumar, first speaker. He is there.
Oh, so the first speaker is Anupam Kumar. He is an MD FCCP. He is Assistant Professor of Pulmonary and Critical Care Medicine and Lung Transplantation Unit, Michigan State University. He completed his graduation from Trivandrum Medical College in 2000. He did his master's from University of Connecticut and fellowship in Pulmonary Critical Care Medicine from Cleveland Clinic, Ohio. He is a member of the ACCP and Lung Transplant Steering Committee. He is in the editorial board of several respiratory journals, and he's a speaker. He's an invited speaker of the American Thoracic Society. And he has got a long list of things to say in his CV, but I think we are going to listen to him. There is nothing much better than that. So that is Mr. Anupam Kumar, Dr. Anupam Kumar. And now we come to Dr. Sujith Cherian. Again, he belongs to the alumni of Trivandrum Medical College 2006. He is Assistant Professor of Critical Care and Pulmonary and Sleep Medicine in the University of Texas, McGovern Medical School, Houston. He did his residency in internal medicine in SUNY Upstate Medical University. He is a fellow of Pulmonary Medicine and Critical Care, University of Texas, MD Anderson Cancer Center, 2015. He is also functioning as the Director of Quality Control, Assistant Director of Medical ICU, Lyndon Barings Johnson Hospital, Houston. I hope my pronunciations are correct. He also in the editorial board of several pulmonary medicine journals. He has written multitude of articles, reviews, and some chapters in some textbooks. And this COVID disease has come a long way in its pathophysiology in the past few months. The growth has been so rapid. That is because of such efficient communication amongst all the stalwarts in this world. And we here have two eminent speakers. Let us listen to them. This wonderful session will be moderated by Dr. Fathahudeen, whom I told that is an alumni of Trivandrum Medical College already. He did his MD from BJ Medical College, Pune University, and he is the professor and HOD of the Department of Pulmonary and Critical Care in Ernakulam Medical College. He is also the vice principal. He is the nodal officer for COVID at Government Medical College, Ernakulam. And he is trained in sleep medicine in Australia and thoracoscopy in Marseille, France. So all the three have a lot of international touches here. So I hope all the three of them will do their best in making this a wonderful, wonderful experience for us to remember. Thank you, everybody. Over to the speakers.
Thank you so much for the kind introduction, Dr. Abraham Varghese, Dr. Gopikumar sir, Dr. Joy Manjila sir, and for the introduction from Dr. Indudharan sir as well. Can you all hear me very well?
Yeah. Yes.
Okay, perfect.
Yeah, we can hear you well.
It's my pleasure and honor to be here today to give this topic. And like Dr. Joy Manjila said, I have to thank Dr. Sunil Manjila, who's a good friend of mine, for persuading me to do this topic. And when I was approached, I was very excited about it because, you know, one of the good things that has come about from this pandemic is that there has been so much collaboration between medical professionals, between countries, you know, across continents. And if anything good has come out of it, is that, you know, there's more impetus to do these kind of webinars. And so there is so much sharing of knowledge across countries and continents that I was in fact suggesting to Dr. Joy Manjila sir that maybe we should do this periodically, at least once in a month or something in the future as well, when eventually we attain some sort of normalcy. Now, my topic will be myths, facts, and updates. And the reason why I named it like that is because there has been so much, you know, change and transformation of information over the last few months. And so what was a fact at one point in time, perhaps in March, later on, some of it became a myth. Although a lot of times the lines between what is a myth and what is a fact is very often blurred. And so I'm trying to give you a presentation, a very brief one about what has changed since the pandemic started. Of course, we're all following different timelines. You know, I was in the middle of a pandemic around late March, April, May, when we were in big crisis. Dr. Cherian, my friend, is right now in the middle of a big crisis. So you can see that there has been a change in approach across centers as well. So the way we have planned this session is that I will start with a talk about some of the misinformation that has happened through this pandemic and the evolution of evidence. And then I'll share some information about the current, the current situation of where we are with the use of diagnostics and medications, and are we getting close to the end of the pandemic? And then I hand over to Sujith, who will talk about cases where, he will share personal experiences and will use the evidence that I've used to show you how protocols are being created in different hospitals. So let's see. So like I said, myths and facts, science always starts with myths. And of course, as you progress, there is criticism of myth, and that's how you find a fact. But very often, the line between myths and facts are very blurred. So this is a sobering statistic of where things are in the United States as of, I believe, yesterday. Ever since the first case was reported on January 21st, 2020 in Washington, we have seen a lot of cases, but most importantly, a lot of death. And the reason you can see from the curve is because there has been mixed messages, mixed signals. Social media has been rife with misinformation. There has been, I don't think anything has stoked more political division than this particular topic in recent times, at least in the United States. And also a lack of sense of collectivism in general, so partial adherence to simple recommendations such as wearing masks and social distancing and avoiding social gatherings and things like that. As a result of this is where we are. And the prediction, actually, according to yesterday, was that we may reach close to 300,000 deaths. And if 95% of the population can actually wear a mask, then the statistics say that you can reduce the number of deaths by at least 70% from that. But 300,000 deaths, towards as we approach New Year, is a truly staggering statistic. I'm from the state of Michigan, and this is where things were the end of July. You can see that again, late March and April and May, we were truly in the middle of a crisis. And this is when, I was in the ICUs probably every day and a lot of nights as well. I was staying away from my family, and I'm not alone in doing this. I'm sure there are a lot of us who are doing the same thing, missing family and kids and things. But we, at one point, Michigan State was right after New York and New Jersey. We were really badly. But as of end of July, we have accounted for almost 6,000 deaths. Things got a little better in the middle of June when the governor came down with really strict recommendations, and then we were very thankful for that. But really, as you start opening things back, and rightfully you got to do so, as long as you have right measures in place, you can see that there has been an uptick in cases as well. But thankfully, the uptick in cases, at least in my center, we have not seen a lot of new severely ill patients. There are few, but not like what we saw in late March, April, and May. One of the first things, and again, I'm guilty of this myself, is that when the pandemic broke out and we started getting information of that COVID-19 has reached the shores of the United States, one of the first things, even I told my own non-medical friends that I didn't say that it's like, but there was a sense of denial, there was a sense of preparedness that a country like the United States would definitely be more prepared to handle something like this, and clearly we were wrong. But if you, COVID-19 is nothing like flu. I mean, it is a respiratory illness, but you can see that even the R0, so a comparison between flu and COVID-19, the R0 is essentially an estimate of how many people can be infected by an average individual with the disease. COVID-19 infects much more, many more people than, for example, the conventional seasonal flu. The incubation time is different. COVID-19 can infect people even in the asymptomatic phase, which makes it very dangerous. The hospitalization rates are much higher. About 20% of people can get hospitalized with the progress to respiratory failure rather quickly. And the case fatality rate is also higher than influenza. The influenza fatality rate in the United States is about 0.2%. The case fatality rate, understandably, is a moving number because it is very dependent on how many patients you test, and how many patients you die is, of course, what becomes a numerator. So the more number of tests you do, of course, the case fatality rate does come down. But clearly, it is a much more fatal disease. It is obviously something new for us medical professionals. You can also see that in the amount of death. Influenza takes a lot of lives every year, but it's about 0.8% for 65 plus years. And you can see the graph here what COVID-19 does. And so when the information came out in the beginning, it was more like, okay, well, it's very like influenza. It affects a lot of people who are about the age of 60, 65, a lot of comorbidities, immunosuppressed. But clearly, the population that COVID-19 was affecting was not hospital. A lot of young patients. I mean, I vividly remember a 23-year-old Latino gentleman who was progressing extremely quickly, and we had to place him on ECMO. He did not have any underlying medical comorbidity. So there are isolated patients, but clearly it is not a condition that affects just the older people or just the immunosuppressed. And the more comorbidities you have, even things like hypertension, diabetes, or history of smoking, puts you at risk. The first information when we were dealing with the pandemic in China in March, it came from this paper in China. And we were looking at that, and that's when we started realizing that it is not really a problem for just the older people. You can see that in the age group of 15 to 64, there is a considerable group of people. Granted, the mortality is lesser, and these people do recover. But when you have a large, number of people who are affected as part of the pandemic, even a certain low percentage of people who die comes up to a very large number. But the case fatality rate, how it affects a certain region is very dependent on the demographic. So if you compare it between Italy and China, Italy obviously had a lot of people in 70+ age. And so they were badly affected. There was a lot of mortality. The case fatality rates were extremely high compared to other countries like China, where even the United States, for that matter, the demographic was quite different. So how it affects a certain country is also dependent on the demographic of that particular country. Now, the second, piece of information that we were constantly hearing back in February, March is this is a regular type of pneumonia. Yes, it is a respiratory illness, but SARS-CoV-2, which causes COVID-19, is much more than a pure respiratory disorder. And the reason why I say that is if you look at the pathophysiology, and this is a beautiful diagram from published in Nature Medicine, coronaviruses have been around for a long time. I mean, even before the pandemic started, we used to always test patients for viral panel when they come in with, for example, an asthma or a COPD chest infection. We always see a coronavirus, and that was not SARS-CoV-2, but we have been familiar with coronaviruses. And we have also been familiar with the S spike protein in the walls of the coronavirus that is extremely important for its pathophysiology and as a treatment target. Now, what it does is the S protein has a receptor binding domain, and that binds to the ACE2 receptors. And this sets off a myriad of effects. So first of all, it has a direct cytotoxic effect on ACE2, but it also causes a dysregulation of the angiotensin aldosterone system, which causes widespread injury and remodeling, inflammation, vasoconstriction, and increased vascular permeability, which causes these patients to be in septic shock. Now, it also causes endothelial cell damage and inflammation. It reduces fibrosis, it increases thrombin production. So a lot of these patients are in a hypercoagulated system, in a hypercoagulated state, and there is a widespread dysregulated immune response. So while it does almost all patients present to the intensive care unit with a severe form of pneumonia, it is still a multi-system disorder. And so there's pretty much no system in your body that is not affected, but significantly in the intensive care unit, what we really see is a lot of acute kidney injury, elevated liver enzymes, and some degree of hepatic failure, and widespread thromboembolism. And Dr. Cherian will be talking about this a little bit more, but you tend to have a lot of deep vein thrombosis. I personally had a patient who was with severe pneumonia, who was getting significantly better, but unfortunately developed a large DVT and then a pulmonary embolism as a result of that. And even while he was recovering from the pneumonia, we actually lost him. We were trying to prone him, and then, he started getting hypoxic, and then, we clearly, he had a large P, and there wasn't much that we could do for him after that. So it is a multi-system disorder. I put this slide out here because the first time that we were getting prepared to manage these patients in the intensive care unit, the social media was rife with information from Italy. This gentleman, this very highly published intensive care unit doctor, Dr. Gattinoni, actually sent out this information that there are two different types of phenotypes within COVID-19. There is an H phenotype and there's an L phenotype. And without going into the details, if you look at the figure, the L type on the CT scan, there is very minimal lung parenchymal involvement, while on the H type, there is a lot of non-aerated tissue. And so he proposed that there are patients who are similarly hypoxic, but their lung involvement is different because of different pathophysiology, and that we should be altering the mechanism of ventilating these patients. So we have to move away from the conventional low tidal volume ventilation that we use for ARDS patients. And that he also proposed that a lot of these patients could be silently hypoxic. A term called happy hypoxemia has been floating around, and that these patients should be intubated early. This was challenged because what happened was in March, we were getting phone calls from outside hospital physicians that I have this patient in the emergency room. He's on 50% on a non-invasive ventilator, which is a BiPAP machine, and he has lung infiltrates. I'm going to get ready to intubate. And it turns out that when we talked to the physician, it almost sounded like this patient had lung infiltrates from heart failure. So this information that you have to intubate this patient early set off a real panic. So patients who are even on like 5 liters, 6 liters nasal cannula with a little bit of pneumonia, there was no obvious test. The number of testing that was done for COVID-19 wasn't as rampant then, and it was certainly not that quick. So we were getting calls about intubating these patients. Now, what this does, or what this did, was that you intubate these patients, and all of a sudden you're using up ventilators, you're using up a massive amount of resources, and when you finally have the influx of COVID-19 patients, then you run out of resources. So the counter to this call for quote unquote early intubation was that, no, you have to still stick to the basics, and let's do what we always did. Let's stick to the basics. And so the likes of Dr. Tobin, who is an eminent figure in the field of mechanical ventilation, pushed back this idea and said that there is this concept of patient-induced self-inflicted lung injury is a notion that Dr. proposed, and that it's more theoretical than what is considered to be. And so he said that let's just stick to the basics, and that's essentially what we followed. So we added more tools. So while the initial group shied away from using tools like high flow oxygen and BiPAP, we did resort to using a lot of high flow oxygen and BiPAP. Certainly for patients who were progressing, we were intubating them. But you can see here, even in figures, that even people on, I mean, this picture is somebody on high flow oxygen. It's the more happy person. This is not a person with COVID. But the other person on the other side, you know, we were proning patients who were even on high flow oxygen. We were actually helping some patients. BiPAP, you know, we were using this, you know, kind of primitive technology where we used helmet hoods to provide positive pressure with an expiratory valve. This also allowed, you know, less of a dissemination of aerosols. So the concern with using BiPAP and high flow was aerosol generation risk to healthcare workers. But we still felt that we could help a lot more patients by using these tools to avoid mechanical ventilation if possible. We're partially successful in that. So what exactly is early intubation? We still think intubation, you know, you have to have a low threshold for intubating, but that doesn't necessarily intubate anybody who is, you know, gone from 3 to 5 liters of oxygen. A lot of things depends on a clinical and objective parameters. Now, you have an anticipated difficulty with intubation procedure. So, for example, a large body mass index, short neck, you know, you expect that intubation is challenging. If that person is progressing along, even if it's a little slower, you may want to consider intratracheal. You feel like respiratory fatigue setting in. So patients pulling higher tidal volumes is tachypnic, mental status is declining. That calls for an endotracheal intubation. There is worsening oxygenation despite the tools that I've shown you. There's worsening hypercapnia showing, suggesting that you're using your ventilation. There is hemodynamic stability, instability. That is hypotension and progressive refractory septic shock. And there is basically a case of progressive multi-organ failure. So new acute injury, liver enzymes, and signs are basically what's called the cytokine storm. These are prognostic markers, and these are indications that we used amongst several others. Of course, there's a lot of subjectivity in this that to decide on who needs to be intubated and who should not. Now, I'll move on to hydroxychloroquine and spend a couple of minutes here because hydroxychloroquine has been widely used in the context. Some of you probably know that even in America, this medication is practically stoked a lot of political with some people endorsing it more than others, and with even a background of a lack of this. Now, hydroxychloroquine was initially thought to be very effective. The French small studies, in not even randomized studies, showed that hydroxychloroquine was helpful, but later on, a couple of randomized control trials have come through. And so this particular one, where they used hydroxychloroquine in combination with azithromycin, mild to moderate COVID-19 patients. And what the graph means here is that, so you have a 7-level ordinal scale. So you move from 1 to 7, you know, that's a severity of patients. You can see that the number of patients in the 3 groups of hydroxychloroquine plus azithromycin, hydroxychloroquine and control were essentially not very different at all, suggesting that it was not beneficial. And actually the people who are on the combination of hydroxychloroquine and azithromycin had prolonged QT intervals, which could be toxic, and also liver enzymes. For hydroxychloroquine for post-exposure prophylaxis, this was recently published in the New England Journal of Medicine, where they compared hydroxychloroquine to placebo to see if you were exposed, and these are people who are truly exposed to COVID-19 patients, would it be beneficial to take hydroxychloroquine at all? And again, the results suggested that whether it comes to a new diagnosis of COVID-19, development of symptoms, any hospitalization, it did not really make any difference whether you were on hydroxychloroquine or placebo. And this is obviously the purpose for the study was that hydroxychloroquine is suggested to have some in vitro activity against viruses. Dexamethasone generated a lot of interest as an anti-inflammatory agent. And now, while my center shied away from using dexamethasone, we felt that you know, it could be an immune suppressing effect and actually contribute to more weakness and high blood sugars, and we shied away from it in the very beginning for a short period. Some centers were already using it, but dexamethasone was studied in this study called the recovery trial, randomized control trial. And while I won't go through the entire trial, you can see that for patients who are on invasive mechanical ventilation, for patients who are requiring oxygen, the use of dexamethasone had a positive effect on the 28-day mortality, while for patients who had milder forms of disease, who were not on oxygen, dexamethasone did not really make much of a difference. And Dr. Cherian will talk to you about how it is used now for COVID-19 patients. Interleukin-6 has again generated a lot of interest because, like I said, COVID-19, SARS-CoV-2 sets off a massive, activation of the inflammatory cascade. So there is, widespread interleukins and TNFs floating around, and the result of this, these cytokines being activated, that there is fever, impaired hematopoietic function, DIC, liver damage, acute kidney injury. So there is a massive inflammatory response within the host. And so the role of cytokine inhibition was studied. And so IL-6 inhibitors have generated a lot of interest. The one in particular has been tocilizumab. There is a randomized trial going on right now. We don't have any RCD, large-scale RCD. But one of the prospective studies showed that there's a reduced risk of mechanical ventilation and death in patients with COVID-19 who use this medication. There is, however, an increased risk of secondary infections in these patients, more bacterial infections in patients who received. Remdesivir has been going the rounds for the last couple of months. The long and short of remdesivir is that right now it is used for patients with severe COVID-19, SpO2 less than 94% improvement, requiring supplemental oxygen. The guidelines of some centers especially still say that they use mechanical ventilation and patients are ECMO. But if you look at the recent report that came through, if you see that comparing remdesivir versus placebo, for patients not receiving oxygen, which you can imply that is very early on in COVID-19, and even for patients requiring some degree of oxygen, the remdesivir was better. But as you progress through the illness, for those who require high flow oxygen, BiPAP, and finally, when you get to that reach where you're receiving mechanical ventilation, as you probably know, in our section for COVID-19 patients in the second. So by then, the effects of remdesivir are not so much. So while guidelines like these do exist in our center, especially for patients on ECMO, we are deciding that we are probably not going to use remdesivir, especially because it's not like these medications are available widespread. So we have to be very selective in using them. Now, this is a glimpse into the future. Now, what happens to these patients? I mean, statistics don't tell you the whole story, right? I mean, it's not just death and people who don't die when it comes to COVID-19. It's also about the morbidities, the chronicity of illnesses that patients with COVID-19 who survive this illness have to go through once they get out of the hospital. A lot of these patients undergo tracheostomy. A lot of these patients go to what's called long-term acute care or nursing homes, further care and aggressive physical therapy. A lot of these patients have mental, physical disabilities. There's loss of employment, so there is a huge impact economically on families. But what happens for these patients is, especially when you have such widespread activation of IL-6 mediated lung damage, we are thinking a lot of these patients that have fibrotic lungs. And you know what percent we'll probably see in the next couple of years when we start getting follow-up of these patients. But Dr. Ganesh Raghu from University of Washington is a very widely published pulmonologist. His group sort of put together this framework of now you start seeing these survivors, and actually there are some hospitals in the post-COVID-19, post-ARDS clinic, that you have to have a short or a low threshold for following up these patients. For example, serial PFTs, chest X-rays, high-resolution CT scans periodically, because these patients can develop fibrotic lung disease. And so what framework and what schedule you use is kind of dependent on the institution you work in. You have to keep in mind that these patients will need kind of close follow-up for a period of time because they will have some form of respiratory limitation eventually. This is actually you can see the explanted lung here. This is the grossly damaged lungs of this particular young girl who was the first lung transplantation, double lung transplantation in the United States of America. It was performed by a surgeon of Indian origin. I just came to know that there's a second transplant happened as well for another person in my center. We actually wrote a approach for lung transplant, one of a physician's brother who was in a hospital, had COVID-19, and I mean, kind of everything got better from rest of the body standpoint, but he was left with densely fibrotic lung, and so he was depending on the mechanical ventilator, but he was awake. We were sort of in a limbo, and we had this patient transferred over to our center for lung transplant evaluation. Unfortunately, as we were progressing with the evaluation, he decompensated. We had to place him on ECMO, and we did not proceed with transplantation. But we are in the transplant community. We are anticipating that we will start seeing some fibrotic lungs for these patients who recover from COVID-19 to be valid for transplantation. This is just an idea that I'm proposing that is getting popularity in the infectious disease world about testing. And so you realize that the RT-PCR is a gold standard for diagnosis of COVID-19 presently, although, again, there are no numbers for its sensitivity. But you should also understand this concept that's coming through called the cycle threshold of the PCR, meaning the cycle threshold reflects the viral load. So if you have less number of cycles required to give you a positive result, it means you have a high viral load. So you can see here in this graph here that about when the cycle threshold, which is plotted in the X plot, gets to a number of 35, the viral load goes down substantially. So what we think now is about when you have a PCR that's positive and a cycle threshold of about 35, the viral load is so low that you're probably not that infectious or contagious. You can see also here that when do you reach that cycle threshold of 35, or when do you reach that point when your viral load is so less? And you can studies here show that if you compare the CT value, which is a cycle threshold value, it's a day since symptom onset, you reach a cycle threshold value of 35 about day 7. So you have that short period in the asymptomatic phase and that brief 7-day period in the symptomatic phase of COVID-19, where you're supposed to be highly contagious and infectious. The other limitation of RT-PCR is, of course, that it takes time, it's expensive, and it's not widely available. So the testing out of a pandemic requires you to test patients very frequently, rapidly, and affordably. And there is an increasing thought that PCRs may not be the way to go. Probably antigen testing is obviously less sensitive, but the question then is, do you really need that sensitive of a test? Because if you have high viral loads and the contagious period, you could probably pick up a positive patient just with antigen PCR. So that could be the future as far as testing is concerned. There is also a lot of interest in vaccines, and we are moving fast through this. So typical timeline of vaccine development is shown here, that you spend about 2 to 10 years through the phase 1 to phase 3. Because we have known about coronaviruses for the last several years, we have known about SARS-CoV for a long time. We have been aware of the S protein, the spike protein in the walls of the coronavirus, and we know that it's a therapeutic target. And so the familiarity with the virus has allowed multiple companies across the world to start working on vaccines. A couple of reports have come through. These 2 were published in the last 2 weeks, actually the last 3 weeks in New Journal of Medicine, showing that an RNA vaccine against SARS-CoV-2 could be effective and was successful in developing and neutralizing antibodies. And the first one was done actually, the report was in humans. So in summary, I'll sum it up. My idea was to give you a state of current evidence, the progression of evidence, and tell you what was a myth at what was a fact at one point turned out to be a myth, and what is a fact today could in fact turn out to be a myth as well. But the lines are very blurred. But COVID-19 is a severe respiratory form of illness, but it is not just respiratory, as it is a multi-system disorder. The evolution of evidence for treatment is a constant moving target. What we used before 2 months ago is no longer being used, and there are new medications in the pipeline. You have to be cognizant about the follow-up for COVID-19 survivors, especially for those in the respiratory and in general medicine. To be aware that a lot of these patients could be left with lung parenchymal problems, fibrotic lung diseases. Diagnostic modalities of SARS-CoV-2 evolve, and especially in the context of controlling pandemic, we may have to start thinking a little different. Rather than our reliance on conventional PCRs. Vaccines are being developed. There are at least 6 of these that are going to very rapidly. Three of them data that is very strong. The earliest that is proposed with the United States is for the end of December. So we have to see. With that, I will conclude my talk. I don't know if there is time for questions, or we can probably do questions in the end. Dr. Manjila, sir.
Hello.
Yes.
Dr.
Dr.
Fathahudeen.
Kumar, that was an excellent deliberations of a a huge topic about which we are learning. We don't know what is going on, but whatever is available in the last 6 months, every day we are learning. Though this virus is so invasive, we hopefully would try to control this pandemic at some point of time. A lot of research and explosion of information is going on. I think we will take up the questions at the end of the second speaker, so that you both can actually contribute together. I think we'll just move on to the next speaker, again, a Trivandrum Medical College alumni, Dr. Sujith Cherian. He has been introduced by the chairperson earlier, and he's basically a pulmonology and critical care physician, and he's working in Houston Critical Care Hospital. And Dr. Sujith Cherian, he's going to speak about the critical care experience in managing COVID-19. Over to you, Dr. Sujith Cherian. I think he's around.
Dr. Anupam Kumar.
Yes.
Screen
Please go
sharing
on.
Screen sharing on the matter. He has not
Yeah.
seen the screen.
Okay.
Yeah.
Thank you, everybody. Good evening. My name is Dr. Sujith Cherian. Thank you again for all the wonderful introductions. As was told before, I am an alumnus of Trivandrum Medical College. And it is a pleasure and privilege for me to be a speaker on this podium for IMA. As I said, back when we were in medical college, this was something I would look at with awe when when IMA speakers, or when people would come and speak at the IMA conventions. And it's truly a privilege for me to be here. And I especially thank Dr. Abraham Varghese, sir, Dr. Gopikumar, sir, Dr. Joy Manjila, sir, and Dr. Indudharan, sir, for introducing me and welcoming me and inviting me for this talk. So I'm going to continue from where Dr. Kumar stopped, and what we are going to be dealing, or what we're going to be talking about, is the Houston critical care experience. This that you see is the Texas Medical Center, which is the largest medical district in the world, and this is where we primarily work at. So I'm going to be talking about basically how we came across this COVID-19 in Houston, and then a few cases from here on. So starting with, I'm going to talk about the epidemiology clinical presentation, which most of you have some idea, but I'm going to just touch upon that. We'll talk a little bit about complications, about radiological manifestations, and then I'm going to be describing about 4 different cases that I had. And then we'll talk briefly about critical care management. The evidence has been already discussed by Dr. Kumar to a certain extent. And then eventually I'm going to start with our approach that we have to these patients. So as most of you are already aware, USA is still having the highest number of cases with COVID-19. India is following closely and getting there rapidly. So as Dr. Kumar mentioned, initially the cases were more concentrated in the northeastern part of the US. And since June, the focus has shifted to the southern states. And I'm in the state called Texas. And right now, Texas has more than 400,000 cases, getting close to 500,000 cases actually, and stands third in the highest number of cases in the US with COVID-19. So this is a graph depicting the total number of COVID-19 patients which we have in med-surg beds in the Texas Medical Center. And in the Texas Medical Center, we have close to around 20 to 25 institutions, or in 25 different hospitals. And this is a cumulative number of patients which are in the med-surg beds in the Texas Medical Center. And as you can see, starting from mid-June, it has been a fairly steep approach, or a fairly steep onset of number of cases and admissions. And then hopefully we are beginning to see a little bit of a decline, but it's still pretty high. And it is a severe illness, as Dr. Kumar already mentioned, and as most of you all know already. So at this particular time, we have a greater than 100,000 patients in Houston itself. And as you can see, when in the beginning, where there were close to between 1,000 to 2,000 cases reported, the number of admissions were between around 200s, while when we get to the 10,000 mark here, around 1690, around close to 1750 patients were getting admitted on a daily basis. Okay, and then going to the ICU census, if you can see out of this, close to 1/3, or probably close to around between 20 to 25% of these patients would fill up the ICU. So the reason why I wanted to share this is, as the number of cases increase, then the number of patients getting to the hospital, which is usually 20% of the number of cases, will increase, and consequently ICU admissions will also increase, which is usually around 10% of the total number of cases, or around 20 to 25% of the total number of admissions in the hospital will end up in the ICU. So, and the other thing I want to just point out is the ICU number of cases will decline rather slowly, because they require a much longer time in the ICU as compared to just on the regular ward. So, I don't mean to scare you, but then this is something which we should be prepared for, given the steep number of cases which have been increasing in India and beginning to see in Kerala as well. So, as of now, we have treated around 18,000 patients from the census around 2 days back, and 15,000 patients have been discharged, which means there are around still 3,000 patients still in the hospital. So I'm gonna stop there about the epidemiology and talk a little bit about clinical presentation. And this we will go through a little bit more faster because most of you are aware of this. But the idea is, as far as the incubation time, the mean incubation time is around 5 days. Around 97.5% of the patients will get the infection after the exposure within 11.5 days. And as the transmission is understood as of now, at least, is generally from droplets and from face-to-face contact, and probably via contaminated surfaces. Aerosol spread may occur. However, the role for this, or the role as to how much this plays in the transmission, is not very clearly understood, but it's believed to maybe play a part. As far as the time from symptom onset to hospital admission is a average of around 7 days, and it may vary between 3 to 9 days. And the idea is, once patients get infected due to certain host factors, due to probably the amount of virus that may be inhaled, as well as certain host factors, around 20% of these patients will get sick, and then they come in with shortness of breath and the beginning of pneumonia at an average of around 7 days after symptom onset. The median age of hospitalized patients is between 47 and 73 years. And based on and at least 74 to 86% of these patients are aged at least 50 years or higher. And common symptoms include the first three that we have mentioned here. One is fever, second is dry cough, and shortness of breath. And these three are the more common symptoms that patients come in with. Within the US, we have seen a lot more GI symptoms, while in the Chinese series, it wasn't described that often, or it wasn't that frequent. Rhinorrhea, or just upper respiratory symptoms with nasal congestion, is only seen in 7%. And a unique symptom which has been described in multiple case series is the presence of anosmia, But it's usually described along with other manifestations as a sole manifestation. It's seen only in around 3% of patients. Now, with regards to the course and complications, and this is where the things get very tricky, and as we already mentioned before, less than 1% of the patients in influenza really get sick or with really bad pneumonia and ARDS. While in the COVID-19, the patients who have mild diseases is only around 81%, while the patients who have severe and critical manifestations are form the remaining 19 to 20%. And how do you define severe? This is based on the Chinese CDC definitions. It is defined as dyspnea, hypoxia, or greater than 50% lung involvement, which on imaging, which develops within 24 to 48 hours. And critical is defined as the presence of any organ failure, and the most common is hypoxemic respiratory failure, presence of shock or multi-organ dysfunction. And it should be understood or remembered that the incidence of complications is much higher in hospitalized patients. So as we all know, it is primarily a respiratory illness. Pneumonia is the most common complication which may develop. And the reason is in hospitalized patients, around 75% of the patients come in with shortness of breath, and the most common manifestation or the most common reason why they're short of breath is because they have pneumonia. So in the vast majority of hospitalized patients, pneumonia is the most common manifestation that you will see. The important thing which may set this virus apart from other viruses is the development of respiratory symptoms is usually after, like we said, around 5 to 7 days, as against other viral illnesses where the pneumonia may actually develop much sooner. So, but to keep in mind is that once patients develop pneumonia, to progression to ARDS is much faster. So at a mean of around 2 to 2.5 or 2 to 3 days, patients who have pneumonia and who develop ARDS will develop within that short phase of time. And ARDS will develop in around 15 to 30% of patients and is the most common reason for ICU admission. As we said, ICU admission is usually or maybe required in around 17 to 35% of patients based on different case series, and is definitely our experience as well. Now, as Dr. Kumar mentioned, it is a respiratory illness with multi-organ manifestations or multi-organ dysfunctions associated with it. And the second most common organ to be affected are the kidneys. And acute renal failure develops in as high as up to 35% of patients, out of which half of these patients will require dialysis. So 15 to 20% of these patients will require dialysis, and the numbers are higher, especially in hospitalized patients. And this is basically pertaining to hospitalized patients. Now, if you look at the data in general about all patients with COVID-19, renal failure develops in around 10% of these patients. But it is important to note that while patients on the mechanical ventilators, around 90% of them will develop acute renal failure. And out of this, around 97 up to 97% of patients may require renal replacement therapy. And based on my personal experience, once they get to that point, the chance of mortality increases tremendously higher. Once they get to that point, the number of patients being able to be salvaged become very less. Now, liver dysfunction develops in around 10 to 19% of patients. They don't generally develop acute liver failure. There's some elevation in LFTs is what the common presentation is. Cardiovascular complications actually has been reported more often in the US, not much seen in the European case series or in China as well. But in one series, it was described in up to 33% of patients, but accounting for different case series in the US, it was cardiovascular complications have been seen in around 7 to 17% of these patients, and which mainly are in the form of atrial arrhythmias and myocardial damage with troponin elevation. The development of true cardiomyopathy is probably much more rarer and seen in less than 5% of patients. Personally speaking, I've had only one patient who developed like a new cardiomyopathy or worsening cardiomyopathy from this. And the other intriguing manifestation, and this is something which again Dr. Kumar touched upon, is the development of clots. And these are venous and arterial clots which develop in up to 25% of patients in if you take hospitalized patients, and it may be as high as 59% in the ICU population. Shock as such is not as common, and multi-organ failure or septic shock is not as common. It's around 5 to 10%. And the other unique manifestation of this is the development of neurological issues. And the other side of it, this is once they get to being on the mechanical ventilator, the amount of sedation required is very, very high. And this results in a significant amount of delirium seen in these patients as soon as you start to come down on the sedation. So, it may be related to the amount of sedation that you have to give in order to control them or to keep them synchronous with the ventilator while we have them on the ventilator. The rare complications have been like a hemophagocytic lymphohistiocytosis or a macrophage activation syndrome kind of a picture, or a cytokine storm, which can develop in a rare minority of these patients. And the other manifestation are cerebrovascular and neurological complications, which may develop in up to 10%. So as we said, respiratory illness is the most, or ARDS is the most severe and the more common complication, but it comes with other myriad of other manifestations, and as we said, a multiple other organ failures which may develop secondary to this infection. Now, as we said before, hypoxemic respiratory failure is the most common reason for ICU admission. As we mentioned before, mechanical ventilation was initially recommended for patients when they got to greater than 6 liters. And as we began to learn more and more things, it was, and then the idea that patients should be kept on the mechanical ventilator was to basically try to protect healthcare staff, or to, because in order to prevent aerosolization, and that was part of the idea in this. But as we said, this resulted in a ventilator shortage and other complications associated with the mechanical ventilators. So as we said, once they develop shortness of breath, the progression to ARDS is very fast and around a median of 2.5 days. The duration of mechanical ventilation tends to be long, at least 2 to 3 weeks. Secondary bacterial pneumonia rates have been traditionally lower, but now, in my personal experience, and when I discuss with this different physicians across the state or within the medical center, the number of secondary bacterial pneumonias have been increasing, and this may be related to the dexamethasone that we have been using based on the recovery trial. And in our series and in series in California as well, the risk of secondary infections have been as high as 20%. And now the question is, why would patients who develop pneumonia progress into ARDS, and which are the things that you should look for, or what are the risk factors? They're still not clearly understood, but what has been seen more commonly in different case series and different cohort studies or retrospective cohort studies is age is a big factor. The presence of multiple comorbid conditions, especially diabetes. Hypertension is probably the more common comorbid condition which is seen in these patients, but again, in my experience, I think diabetes is the one which puts them at higher risk for developing ARDS, and this is in contrary to what you would see in other regular ARDS patients, where diabetes actually puts you at a lower risk for developing ARDS. But this is not the case for COVID-19. And another very big thing is the BMI, right? Being in Texas or being in Houston, where the proportion of patients who are obese is very high, that seems to be a very big risk factor for the development of ARDS, especially in younger patients. And I'm going to show this in this study, which was published in the Annals of Internal Medicine. And as you can see in the second picture lower down, as the class of the obesity increases, and class 1 is BMI of 30 to 34.9, class 2 is 35 to 39.9, and class 3 is 40 onwards. as you see, the mortality increases with the as the BMI increases. So even BMI greater than 30 is puts you at an increased risk. And it's probably, like we said, a multitude of other things, but and multiple other factors, probably including the amount of virus that you have inhaled, which may put the body at increased risk for developing ARDS. But the role of that is not very clear. There was a study published in the New England where they evaluated the Italian series where blood group type A was considered to be an increased risk factor for development of ARDS as well. And the top picture here I'm showing is basically how the mortality increases as the age increases. And as you can see, with as patients greater than 85, the mortality is around 304 patients per 1,000 COVID-19 cases. And it basically takes an uptick starting from 40 onwards, but much more higher when you start from 50 years onwards. So no really laboratory findings are specific for COVID-19. What has been commonly described is reported is lymphopenia. And it is most people and most hospitals and once we deal with COVID-19 patients follow the markers of inflammation, CRP, ferritin, and LDH. And this is to see if they may be going into the cytokine release phase, which is one of the later phases in COVID-19. And out of these, and as we discussed before, a coagulopathy that these patients develop is something unique in this population, and it's likely because of the endothelitis or endothelial inflammation that develops, or because of the vascular invasion from this virus. So the worst prognostic factors specifically relate to lymphopenia and an elevated D-dimer across when looking at specifically pertaining to lab findings in this disease. With regards to radiological findings, this most people are probably aware of, but what we generally see is a peripheral-based, poorly defined ground glass opacities with or without thickening of pleura or interlobular septal thickening. As we said, pleural disease, mediastinal adenopathy are extremely rare. And to keep in mind is chest x-rays may be normal in around 40% of patients up front. And if you actually do a CT in those patients may also be normal. Although there may be patients who have asymptomatic findings. And that's why if you look at the number here, CT scans may be able to demonstrate early findings, while a chest X-ray will be read as normal in these patients in many of these asymptomatic cases. And I've had a couple of patients who came in with just diabetic ketoacidosis, and they found to be COVID positive, and their CTs did show initial ground glass opacities in the base and in peripheral based opacities. However, they were not really symptomatic. They did not require any oxygen, and they actually did well. So I'm going to describe on a few cases that we had. I'm going to talk about 4 different cases here, and each of them had different outcomes, or the course that they had was different. And this is basically just to highlight how the ARDS differs or behaves differently in different patients. Okay, so this is a 57-year-old patient, and he actually was a church pastor, and he was sharing a ride with one of his friends, and he found later that he was actually COVID positive, and that's how he got the infection. So he initially came in with diarrhea, fever, cough, found to be COVID-19 positive, or basically tested positive for COVID-19. He had poorly controlled diabetes. BMI was around 30-32. Initially came in, then given increased oxygen requirements, he was transferred to the ICU after 4 days after admission. We initially attempted high flow oxygen and self-fluorine, which Dr. Kumar just described. However, after 4 to 5 days, due to increased respiratory work of breathing, he had to be admitted, he had to be intubated. And we initiated lung protective settings on the mechanical ventilator, started remdesivir, gave steroids. And, this was his chest X-ray when he initially presented. And you can see how the patient had these peripheral based opacities. And you can't say ground glass because this is a chest X-ray, but you can see how it is almost consolidative and more peripherally based and beginning to show more in the lower lobes as well. And this is a chest X-ray done on the 7th of June. And fast forward a month later, the chest X-ray is almost a month later. Patient is still requiring a good amount of oxygen on the vent. He's intubated, and we had been proning him. We adopted early proning in these patients, and this is on exactly a month later. Fast forward another 2 weeks, and given his high increased weakness and increased critical care illness, polyneuromyopathy that he had, and this is now, mind you, we're looking at almost 6 weeks from initial admission. We performed a tracheostomy, and he was discharged actually around 3 to 4 days back. And but if you look at the last chest X-ray at 6 weeks, we still see these reticular opacities that you see here. And bringing back to Dr. Kumar's point about the incidence about the possibility of developing fibrotic lung disease, this may be, this probably could result in that eventually. Which we don't know, only time will tell. Okay. So this is one patient who had a prolonged hospitalization in our ICU. I'm going to take to the second patient, and this is again a very young patient, a 33-year-old Hispanic man, a Latino man from Mexico, originally from Mexico, but basically morbidly obese, BMI of 44. Diabetes was slightly on the slightly diabetic, A1C of 6.6. Hypertension, came in with the usual complaints of COVID-19 with shortness of breath, fevers, cough, found to be COVID-19 positive. And this was one of those where even the whole family was infected. Both the mother and the son were in our ICU. Fortunately, the mother got better, but then this is presenting a poor outcome in our patient here. And initial CT scans when the patient came in showed the typical ground glass opacities that we see, or more or less consolidated here. And you can see how it's more peripherally based, as well as a lower lobe predominant densities. Chest X-ray after a week later when he came to our ICU and getting intubated is shown up above here, and he's intubated here. Opacities are much more in the left side, but you can see how the peripheral based opacities are there and very consolidative. 2 weeks after this is how his chest X-ray looks. And at this point, I'm thinking about actually trying about a possible extubation in him. And because if you see in him, and I was actually putting down on his FiO2 down to 40%, and he's reaching what we call extubatable settings. And his chest X-ray also looks fairly good. And I'm looking at this, but then the patient now starts to develop fevers. We pan culture him and don't really find a particular organism. We start him on broad spectrum antibiotics. He's requiring multiple doses of pressors. And he is on anticoagulation, therapeutic anticoagulation as well. But the patient has ferritin levels greater than 7,500, temperatures as high as 108 to 109, with really high CRP levels found. And the patient subsequently died. So this was a cytokine release phase syndrome, or CRS, or HLH, or a macrophage activation syndrome, which we suspect that the patient developed. The family declined autopsy, so we don't really know, but that is what I believe or suspect that the patient had. And unfortunately, the patient died in 3 weeks after admission here. Now, this is the third case, another very young patient, 27-year-old, again, Hispanic woman. And as I said, the incidence of obesity or prevalence of obesity in Houston is extremely high. The only risk factor that this patient has is a BMI of 43. And the patient has no other medical problems. Patient comes in with shortness of breath, cough, found to be COVID-19 positive. And as I said, no other medical problems or comorbid conditions. This is the chest X-ray when the patient comes up front. As you can see again, diffuse opacities. The consolidative opacity and initial chest X-ray when the patient was admitted to the wards And as we said, patient rapidly deteriorated, got admitted to the ICU, was on high flow, but increased work of breathing. And then the patient had to be intubated. And this is the chest X-ray soon after intubation. And as you can see, this is diffuse consolidative opacities, which is filling up the lung. You really can't see any lung parenchyma at all. It is a diffuse air bronchograms and diffuse consolidation. And we adopted, again, early proning in this patient, started the paralytics, started lung protective ventilator settings. This was before steroids were, this was before the study on steroids came into play. So she just got remdesivir, and she required a duration of hospital, she remained in the ICU or on the mechanical ventilator for around 16 days. And we extubated her at day 16. She followed up in clinic just last month in mid-July. And this is a chest X-ray when we saw her in clinic 2 months later. And you know, what I'm trying to say is there is hope. You can see that the chest X-ray looks almost normal. And the things which may have been in her favor were probably the age, and you can see that the patient doesn't have any reticular opacities, obvious, and she actually looks really good right now. Now, this is a case 4, and this was a patient I had back in April when the epidemic or pandemic had just begun to start in Houston. And he's a 53-year-old Black man or African-American man, BMI of 28. Again, no medical problems, no evidence of hypertension, diabetes. Came in with the typical symptoms of shortness of breath, cough, fevers, found to be COVID-19 positive. And this was his chest X-ray up front. And initially when he came, there was really high work of breathing. But what we did was we placed him on high flow oxygen. And you know, this was a time when they were still recommending early intubation, but I did not want to do it just because he looked, he did not have any other medical issues. And I was beginning to see high durations of mechanical ventilation in these patients. So we put him on high flow nasal cannula. And typically once we put them on high flow nasal cannula, we put a surgical mask on those patients. And we practice airborne precautions when we go into these patients' rooms. And so he was a very motivated patient. We recommended that he do self-proning for as long as possible, and he actually did up to 12 hours per day. And this was his X-ray a week later. He thankfully did not require intubation. He clinically improved significantly, and he was discharged on 4 liters of oxygen. He only got remdesivir. Again, this was a time before steroids were being given. He did not get steroids. And yeah, improved remarkably, actually. So this was a patient we could avoid intubation. So I was basically trying to highlight 4 different routes that these patients took as far as their duration and their ICU courses of stay. So you know, these are possible outcomes which can develop and possible complications which can develop. Now, as far as critical care management is concerned in these patients, it basically belongs along these 5 lines, right? One is supportive management, and there is as of now no magic bullet for treatment as far as COVID-19. There is the antiviral treatment, which we already discussed, remdesivir and favipiravir, which is again both are the RNA-dependent RNA polymerase inhibitors. The antibodies, convalescent plasma, and personally speaking, and my anecdotal experience, I think convalescent plasma, when given initially, is actually makes a significant difference. Anti-inflammatory agents, which include dexamethasone, tocilizumab, and as we talked about, anticoagulants. Okay. So as we talked about, the pneumonia is the most common manifestation or the most common complication that these patients develop. And around 15 to 30% of these patients will require ICU admission. So, and the deterioration is fast. And as Dr. Anupam Kumar said, although the initial discussion was that once they get to greater than 6 liters per minute, that these patients, that mechanical ventilation should be instituted early. There were the patients which were termed happy hypoxemics, which meant that they would not have too high of a work of breathing, but they were hypoxemic. And in those patients, especially those patients, we adopted a high flow nasal cannula back as early as back in April, and we attempted to do self-proning based on a few case series which was described. And in our experience, I think around 20 to 30% of the patients may be able to avoid intubation and mechanical ventilation, which is a big thing because as we discussed, mechanical ventilation and their course of stay in the ICU may be really long, going up to 6 weeks in some cases. And along with that comes a lot of other complications as well. So if possible, and if their work of breathing is not high flow nasal cannula and self-proning may be a game changer. But it is important to keep in mind that these patients should be carefully observed. And if they have increased work of breathing, then and things don't change within 2 to 3 days, then we should probably go ahead and try to perform intubation and put them on mechanical ventilators. And the usual or the general recommendation is that the airway experts should perform endotracheal intubation, which we have anesthesia here do that. And this should always be done under strict airborne precautions. Non-invasive ventilation such as BiPAP or BPAP or CPAP is generally not recommended because of the high failure rates which have been historically reported in ARDS or other hypoxemic respiratory failures. And with the MERS or the Middle Eastern CoV virus or coronavirus that was back in Saudi Arabia, it was shown to have a high failure rate and high mortality rate. So basically delayed intubation in those patients were higher, resulting in higher mortalities as well. So as we said, early proning, early neuromuscular blocking agents with maximal sedation and low tidal volume lung protective settings with high PEEP is the general ventilator settings recommended in these patients, because this has been a time-tested approach and have been shown to have mortality benefit. And I would say that the ones where we've had really good success have all been patients where we have instituted these strategies with early proning. And early proning means between as early as 24 hours, as early as even 12 hours. Antiviral treatment, we talked about this. Remdesivir is given usually in the first day at 200 milligrams, and then 100 milligrams for 4 days. And this is benefit really seen only in patients with low supplemental oxygen. Generally speaking, all the patients who come to the ICU who have COVID-19, we give this, and we give it only for 5 days and not given in the setting of renal failure or elevated LFTs if ALT is greater than 5 times normal. And there was a trial which showed benefit with 5 days versus 10 days. And that's the strategy that we use with only 5 days. But here's the thing, as far as the efficacy, as far as patients are concerned, if patients are on the ventilators, the benefit of this is questionable. So if there is a shortage and you have a patient on the wards versus a patient on the ventilator who has COVID-19, the recommendation the general consensus should be that the patient on the floor should get the remdesivir, because that is a group of patients where they have the maximal benefit. These HIV medications did not show benefit in another study. As far as antibodies, and this is based on my anecdotal or our anecdotal experience, convalescent plasma, if given early in the stage, and this is when patients start developing shortness of breath before they go into full-blown ARDS, the institution of convalescent plasma, I think in my experience, has been a significant game changer in those patients. So once patients get short of breath and have pneumonia, and this based in the US, this is specifically reserved for patients who have severe and critical, and by definition, it means anybody who's really short of breath or is hypoxemic. Convalescent plasma has been shown to be very much beneficial. Now, once the patients are on the mechanical ventilators and have developed into severe ARDS, whether it really results in a big difference is questionable, at least in our experience. As of now, there are future trials, or there are trials and studies ongoing in this area. So the only evidence so far is from a small series in China, in JAMA, which did not show any statistically significant difference in mortality. However, it did show a difference with improvement in clinically in these patients. Now, anti-inflammatory agents, I know Dr. Anupam Kumar discussed about this, and this has been the only medication which has been proven in a randomized controlled trial so far, apart from remdesivir, to show a mortality benefit. And it includes patients on the mechanical ventilator as such. But one thing which was not discussed in the trial is the risk of infections. And groups in China where they used a lot of steroids had a risk of infection around 10 to 12%, and we are seeing the same as well here. As regarding tocilizumab, there are mixed data, but in all our patients we saw really high rates of secondary infection. So we have stopped using them within our practice here. And now this is, like we said, an intriguing aspect of COVID-19, a hypercoagulable state has been seen in up to 1/3 of patients when hospitalized, and as high as 43% of patients in the ICU, or actually even up to 59% of patients. And generally what you see is, even if you don't see a PE or a pulmonary embolism, you see clots developing within the arterial lines, central lines, the circuits which are used for dialysis, and in the when you're placing patients on extracorporeal membrane oxygen, there is a high degree of clotting which develops in these patients. So many places differ with their practice. Everybody should be on DVT prophylaxis or deep vein thrombosis prophylaxis. Now, if the D-dimer levels are greater than 6 times normal, which is usually greater than 3 nanograms, it will depend on the physician to decide between intermediate dosing anticoagulation, wherein the dose is between therapeutic and DVT prophylaxis, or therapeutic anticoagulation. And our general practice is to do therapeutic anticoagulation. And the complication you would expect is higher incidence of bleeding, but we really don't see that as commonly in these patients. Perhaps less, around 2 to 3% of bleeding, but otherwise really no high degree of bleeding. It's really the development of clots, which is detrimental to these patients. So in a nutshell, what our approach is as we said, remdesivir and dexamethasone, and our idea is, given this increased risk of increased infections that we are seeing, we are limiting the dose of dexamethasone to 5 to 7 days. Again, not really based on any evidence as of now. As we, going back to Dr. Kumar's point, early intubation is not encouraged. If patients are not having increased work of breathing and are hypoxemic, you should initiate high flow nasal cannula. Remember that they should have a surgical mask. And if you think about it, any patient who is on nasal cannula will have dispersion of viral particles. But thankfully, so far, our respiratory therapists or none of our physicians have become infected, or including the nurses working in the ICU. So the importance of protective equipment with an N95 mask, an adequate protection is paramount to prevent transmission to healthcare workers. But if those practices are implemented and patients have a surgical mask, the risk of transmission to healthcare workers is likely very, very low. So high flow nasal cannula should be encouraged, and self-proning should be encouraged. And as we said, having critical care consult services or pulmonary consult services, is, if available at the hospital at an early stage, is highly encouraged. And as we said, if patients don't improve in 2 to 3 days, then you should consider intubation in those patients. Now, if patients meet criteria for severe or critical illness, then consenting for convalescent plasma is highly encouraged, at least per my recommendation, and in our preference, based on our case series, that is what we usually do. Although a conservative fluid strategy has been encouraged, we should take into account the insensible fluid losses that patients have, while given the extreme tachypnea or hypertonic that the patients have. So I would usually recommend we generally avoid diuretics initially, and we try to keep their fluid balance on the even side. as much as possible. And our general approach and the approach in most of the hospitals is to follow D-dimers on every 2 to 3 days. And we initiate therapeutic versus intermediate dosing of anticoagulation once the levels are greater than 3. And so this is just a flowchart that we have. And as we said, ARDS, we attempt lung protective settings. If the PaO2 over FiO2 ratios are less than 150, then they should be getting paralytics and we consider proning. If the patients are still refractorily hypoxemic with PF ratio less than 50 even 3 hours, consider an ECMO consult or getting the surgeons to initiate ECMO. Or if the patients are hemodynamically unstable, also the same. But generally, in what we observe is, given that these patients have high compliance or the inflammation is more towards the posterior parts of the lung, they respond very well with proning, and oxygenation, at least in the initial few days, is our goals are achieved very well with early implementation of proning and paralytics. Okay, I guess that would conclude my presentation. Happy to take any questions along with Dr. Kumar. Dr. Manjila,
Thank you. Yeah, thank you, Dr. Cherian, for that excellent and exhaustive talk. I think both of you have covered most aspect, right from the epidemiology to the clinical presentations to the the demography of patients getting admitted in the ICU and the management in the ICU, and fairly exhaustively touched upon the general management. I know that there will be a lot of questions coming in from the audience. The time management is going to be really difficult. Well, basically, I come from a COVID hospital, probably the first COVID hospital in Kerala from Government Medical College, Ernakulam. And right from the day one, as the treatment paradigm shifted from nothing to antibiotics to azithromycin to hydroxychloroquine to lopinavir, ritonavir, which I still use, and has in the last 2 months with the recovery trial coming in, started using lots of steroids. And in fact, we have formulated something called a dexapron plus anticoagulation, where all patients who require more than 4 liters of oxygen on admission with hypoxemia, with COVID pneumonia, invariably receiving dexamethasone 6 milligram IV once daily, plus self-proning. Anticoagulation, DVT, of course, we were giving, but then the anticoagulation, therapeutic anticoagulation has been fairly all moderate to severe ARDS patients. My patients are receiving enoxaparin 1 milligram per kilogram body weight 12th hourly. And as you said rightly, the bleeding risk is very, very less. So that is a very good point that that is the observation that we made. And you have covered about the diabetes, the Kerala being the capital of diabetes in India. And I had around 5 patients of diabetic ketoacidosis, and I have lost 3 of them. And patients who are obese, those actually came from Middle East. They're obese, more than 110 kg. I had 7 patients, I lost 3 patients upon intubation. And one first question I want to ask is how I use a lot of non-invasive ventilation early in the disease, and only when the patient develops severe respiratory increased work of breathing and the respiratory rate goes more than 35, 40, and the patient is unable to maintain saturation and high flow oxygen, I intubate. And our intubation, most of the patients, we have intubated around 10 patients. So I lost around 6 patients. So 4 patients came out. So probably we are intubating late and your people are intubating early. But our experience with the NIV, non-invasive ventilation, is very good. At the moment, if you ask me, we have 17 patients in my ICU and 10 of them are on non-invasive ventilation with a non-vented mask. And I cycle out through the expiratory port with a viral filter at the end of the expiratory. None of our healthcare workers or doctors got infected out of aerosolization. And this has come in a big way for us. For you, I think you still try NIV. What is your take on that, Sujith?
Yeah, so generally we try NIV, especially in the setting of, like we said, cardiogenic pulmonary edema, if there is a component of heart failure. Or like we said, if the patients, and given like we said, the incidence of obesity is very high, if there is a component of obstructive sleep apnea or obesity hypoventilation syndrome, we try that. In our experience, the ones initially we try is high flow nasal cannula if it is outside these premises. And if patients don't do well and they're getting more hypoxemic while doing this, we still give a trial of NIV or non-invasive ventilation. The problem with that is, as we said, they're not able to eat or drink anything, and there's a lot of fluid loss, and they still have a high work of breathing. And the reason why we try to refrain from doing that much is if most of them will be taking increased respiratory efforts, as you said, rightly mentioned. So the amount of volumes that they're taking are very high, so that puts them potentially at risk for increased lung injury because of high volumes. And that's basically why we have refrained from using it in some patients. But like I said, the patients where we have cardiogenic pulmonary edema or in patients with sleep apnea, obesity, hypoventilation, I have had a good experience, and those patients, we should try that before we try high flow also.
So I think we'll take up questions from the audience, and there will be a lot of questions coming in. And one question was, are we discharging patients on Xarelto? I think that is Roxaban. If D-dimer is more than 32, what is the advantage of trending of D-dimer if it is more than 3 times and we plan full anticoagulation on discharge? So the question is basically those patients who require therapeutic dose of anticoagulation in the ICU on discharge, do they are prescribed oral anticoagulants? My experience, what we are doing is on the Mount Sinai guideline, which you may be knowing, I give them, Apixaban 5 milligram twice a day for 2 weeks. Only those patients in the ICU who actually required or received therapeutic dose of anticoagulation. And your comments on that?
So I can go first.
Sure.
Yeah.
Yeah, no, we debated this.
Any one of you can take up the question. Any one of you can take up the question and just jump and answer. Yeah, so that we can finish.
Yeah, I suspect there is a difference in approach, wherever you go.
Absolutely.
So, when we started, we also obviously were seeing a lot of hypercoagulability. We were trending D-dimers, and as the D-dimers were going up significantly, then we instituted treatment dose of anticoagulation. Although most of the patients are still in the hypercoagulable profile, if you look at the thromboelastograph profiles of these patients, some patients on anticoagulation itself have developed retroperitoneal bleeds. And so, which is what happened to actually a couple of our patients. So we had to scale back on that approach a little bit. What we are doing is for patients who are in the ICU, severe pneumonia, who require mechanical ventilation, and obviously if they had evidence of venous thromboembolism, then they are discharged on full dose anticoagulation. But if their D-dimers are persistently high, and once they get out of the ICU, we were only treating them with prophylactic dose of anticoagulation. D-dimers were serially checked every few hours in the units. Once they were transferred to the regular ward, we were checking D-dimers probably like Q12 hours. And if they are trending down, we stopped trending D-dimers. And if they trended down to a certain point where they were kind of just a little bit abnormal, then we essentially were discharging them home on prophylactic Lovenox doses, which is essentially injectable subcutaneous heparin, like Lexane. So that's what we were doing. We were treating people with full dose anticoagulation only if they had evidence of DVT and or PE, or if they were being discharged from the unit to the floor and their D-dimers were extremely high, which was very unlikely because once they were discharged from the unit, these patients spend a lot of time in the wards also recovering because it's so much background of deconditioning and things from being, they were still requiring a fair amount of oxygen. So that was the approach that we took.
Okay, again to you, Kumar. How often you use CT scan? Sufficiently early, do you go for a CT scan screening, or you just go for an X-ray test up front, then go, or you go for a CT scan screening, CT chest?
You mean for pulmonary embolism?
No, just to see the COVID pneumonia.
So we did not. I mean, I think if we had evidence of chest X-rays like what Sujith was showing, where there is a lot of lung parenchymal involvement and their PF ratio was already meeting criteria for severe hypoxemia and things, I think then you straight away you call them ARDS. We did not feel like CT chest, because these patients very often when they get on the ventilators, they are sedated, paralyzed, and there's a lot of resource mobilization to move them for CT scans. So we did not regularly do CT scans. Early on in the disease, if someone was on a lower amount of supplemental oxygen, let's say we felt like their hypoxemia was little disproportionate to what you see on the x-rays, then we would send them for CT scans, because for some patients, as you know, the CT scans are a little more obvious. I mean, it delineates the lung parenchymal abnormalities better than chest x-rays. But once they're in the unit, they are intubated. We know that we are dealing with severe ARDS. We never did CT scans, partly because we were trying to balance between is an investigation we are doing going to really change the way we are doing things. And if someone was already in very severe ARDS, we were already going to institute all the ARDS treatments like proning and sedation and paralysis and things without even the need for a CT scan. So a very selected group of patients had CT scans, and if anything, that would be very early on before they are in the ICU.
Good, thank you. Sujith, over to you. Sujith. We have been talking about remdesivir as a magic bullet or something, and it is made available in India since the last 6 weeks or so. I have been using in quite a large number of patients, and I'm not using in the ICU, using the moderate ARDS patients sufficiently early in the disease, combining with the plasma therapy. We have, a lot of popularity with the plasma therapy, though the meta-analysis is really doubtful. I do agree with you. But here from Delhi downwards, people have really popularized plasma therapy. So my patients and class of patients who comes with moderate ARDS sufficiently early within the first 7 days of the disease, we are using both plasma as well as remdesivir together. Once the patient has gone to ICU and ventilator, is there any point in using remdesivir? Sujith, what is your take on? And Kumar can add your experience as well.
Yeah, I think I agree along with you, sir. So initially, we have been also, when we had patients up front, remdesivir with plasma, now steroids have also come into play. Be used for a lot of patients, but I don't think when extending this to mechanically ventilated patients, once they get into the critically ill stage, if it is really going to make any difference. And that was shown in the trial as well, as far as mortality benefit or any change in outcomes in these critically ill patients. Remdesivir did not really have any difference in outcomes. So when they come up front early with symptoms and short of breath is the time to institute that. But if say they come like 2 to 3 days after they have shortness of breath and get to the point of being on the ventilator, and we still give it, but like as I said before, if there is a choice, and if you say you have only one single dose, and you have to give it between a patient on the floor or on the wards versus a patient on the ventilator in the ICU, you should give it to the patient on the floor, on the wards, because that is where the benefit.
On the floor. That should be the take-home message than giving late in the disease. Yeah. And another question is, what class of patients do you use favipiravir? Kumar?
So we are not using favipiravir right now. I don't know if Dr. Cherian was using. We never really used favipiravir. We had a very early access to remdesivir. In fact, we never used lopinavir, ritonavir as well. I fully agree with the statements that
we used.
Yeah.
Have been using lopinavir, ritonavir initially.
Yes, I understood that from the talking to my colleagues in India too. So I think because we had an early access to remdesivir, we also had pretty early access to convalescent plasma. I echo the statements that Sujith made and you made, sir, that really the name of the game is to use remdesivir and plasma early on. Because once they are ARDS, the ship has already left the anchor. So by then, there is really no point in using it, especially in the Indian context. It's going to be important when it comes to limited availability. Now, when it comes to favipiravir, we never used it. We just resorted to using remdesivir. I know there is a trial going on right now with favipiravir too, but no, we never.
Some of the Indian companies have come out big way, and they're lot of trials are on. I don't know how
Yeah.
far that is going to be beneficial.
What is your personal experience with favipiravir?
I have used it only for 4 patients with very mild disease. They're just coming with a patch of pneumonia and very mild disease, not even desaturation. So I have used in 3 patients. I don't know whether it has really worked.
Yeah.
Even otherwise, probably they would have recovered. So this is my take on that. So I am not using it at the moment. It has just come in the market. Guidelines in our state also including it. So that is the one.
I think the way we look at the general school of thought for antivirals for COVID-19 is very analogous to the thought for using medications like oseltamivir for influenza, where the only data has been shown is that if anything, you start early, you may reduce the severity of illness. There is, I think it's hard to believe that it's going to do anything more than that. So, I mean, full on support for early institution of plasma and remdesivir.
Absolutely. So the system support, you have to support the system rather than concentrating the viral killing. And regarding tocilizumab, Dr. Sujith, tocilizumab, the cytokine storm syndrome, in my experience, I am seeing it in a large number of patients, in Indian patients who are obese or diabetic. And those group of patients, when their serum ferritin is high, they're still conscious, they're tolerating the arterial hypoxemia, but the D-dimer is going up, their ferritin is going up, and they're increasing oxygen. Oxygen requirement is higher, their respiratory failure is progressing with severe fever, myalgia, extreme fatigability, still conscious. At that point, I have been using it and they responded. In your talks, you said about the bacterial infection. I don't know. All my moderate and severe ARDS patients upfront receive a blind empirical antibiotic. We have not seen any secondary infection in that group of patients. Is that because we are using a blind empirical blanket broad spectrum antibiotic? What is your, both of you can answer with your experience.
I mean, I agree. I agree with you, sir. In the sense, even if most patients are not really, we are not able to culture any organism, everybody is usually on broad spectrum antibiotics. And I think that's a practice all around. We have given initially upfront, we were using it a lot in patients. And basically what we did was following IL-6 levels along with the ferritin levels, like you were saying, sir. So once the levels were greater than 40, we gave it to, I think we gave it around to 7 to 8 patients. Around 2 patients eventually survived. But then out of them, the remaining 4 to 5 patients had other infections while on top of antibiotics. And so, basically our experience has not been that great with it. But I will say to this, again, to your point, sir, that for the patients who responded, they responded really well to that. So
they responded really well, and they are younger patients. They responded really well, and younger patients, not the older ones, which responded.
Yeah, I agree with it too.
Dr. Kumar, diabetic ketoacidosis is a major problem for me, and probably all the doctors probably would agree with me on treating COVID patients in India. What is your experience with that? Sujith has actually shown some of the data on this.
So I mean, yeah, I have seen diabetics, uncontrolled diabetics, present with like Fulmin and COVID-19 and get ill very quickly. I think once they are on the the severity spectrum, as severe as they get, we have a very hard time controlling the sugars. But really, me personally, I mean, this might be a a skewed comment that me personally, because even the demographic of the patients that I take care of is very different from the demographic in Houston, right, Sujith? In Houston, there is more African Americans, Hispanics. There is definitely more obesity. There is a more underserved population with not real great access to healthcare, versus the demographic of population where I am is a little different. So I personally have not had a DKA going into COVID-19. I have had an uncontrolled diabetics going to COVID-19, and of course, their mortality is extremely high. But personally, like diabetic ketoacidosis for me has not been a personal experience. So I don't know if Sujith may be able to tell you more.
Sujith has actually, elaborated upon it some more on that.
Yeah,
because why I am asking this question, why this question I have specifically put is because, Kerala is the capital of diabetes, number one. We have a lot of Mallus who are absolute metabolic syndrome. They are a sitting duck for a coronary artery disease and myocardial infarctions and obesity, hypoventilation syndrome. So if you look at the number of number of Malayalis who died in UAE, 42 of them were in the age bracket of 32 to 52, very younger age group, and they were all obese or diabetic. So diabetes and obesity did really play a role among Indian, particularly Kerala population, in increasing the mortality, both here in Kerala as well as in Middle East. I don't know anything about the other part of the world where Malayalis are living.
No, obesity is a problem. I think obesity is a big problem here too.
Yeah.
In Kerala obesity is as high as probably in the West. Nowadays.
I think the abdominal obesity, but I think obesity was a big challenge for us too, not just as a comorbidity that puts them at risk, but really they do not do very well once they are on the ventilator as well. I mean, the amount of pressures they require, the extent of support, the nursing support and the ancillary support required to even, I mean, you can imagine trying to prone every 16 hours a person who weighs 200 plus kilograms or 150 plus kilograms. It requires a lot of nursing support. It requires a lot of use of PPE, right? I mean, we are running short of PPE. So, I mean, you can imagine trying to flip a person like that. It requires, a use of PPE and things. So obesity, unfortunately, was a risk factor and a bad prognostic marker too for us too. That is true.
So I think we'll take up 2 or 3, a lot of questions coming, and I'll take up only 2 or 3 relevant questions, and probably we'll wind up this session. It's getting too long. Does CT values, RT-PCR cycle threshold, have any relevance to manage critical patient?
Yeah. I don't think, and again, this is my take on it. The CT values is gaining popularity, especially recently, because now we know that CT values correlate with the viral load. And now what has typically been seen is by the time ARDS sets in and they go into this multi-systemic inflammatory syndrome, it is not quite related to the viral load. It is more of a response to the host immune system responding to the inflammatory trigger from the virus that has already been in the body. So the new data, as I showed, says that your CT value, when it hits about 35, meaning that you require so many cycles to finally pick up the test to become positive, because RT-PCR is a very sensitive test, that by the time your cycle threshold is about 35, your viral load is so significantly low. So one, it reflects less contagious periods when your cycle threshold is so high. As far as severity, as far as ARDS is concerned, we never tracked viral load. We never tried viral culture because I feel like at that point, and I think that is the reason why antivirals like remdesivir or even favipiravir maybe will not work that well once they are so severely ill, because your viral load is already low. And now what you're dealing with is not viremia, you're dealing with inflammatory response of the host. So I think tracking CT values may not be that useful. It might be useful in isolating a patient who might be contagious, but I don't think it has value within the hospital.
Perfect. So the next important question is from my own experience. I think I have reported it also in some of the journals, that you see what is called the COVID RT-PCR negative COVID or swab negative COVID, where the patient comes to you with typical desaturation, typical symptomatology, typical cohort of patients who have classical radiology showing the classical bilateral peripheral subpleural ground glass consolidation, increasing recurring oxygen. Their inflammatory markers are on the rise. They have a reasonably diagnostic value of neutrophil lymphocyte ratio with the lymphopenia, most of them in the range of 4, 5.5, things like that, but repeated RT-PCR negative. So this is something which has really caused a lot of problem for the documentation purpose, for convincing the patient to take them into the ICU, to give them medicines like remdesivir and tocilizumab and even plasma. And at the end of the day, if the patient dies due to COVID, they will accept. If the COVID negative pneumonia, then you are in for trouble. I had a couple of patients in whom In two of them, I could definitely retrospectively shown IG antibody test showing highly positive IgM, and I could save my face. So this question is for both of you. I think both of you should be able to tell us about your own experience with this.
Sujith, do you want to take first?
Yeah. So, I mean, in our experience, we have seen a few of those as well. A lot of it is probably related to, as we said before, the sensitivity of the PCR, and especially from the nasopharyngeal swab. For obvious reasons, we don't want to do bronchoscopies in these patients where the sensitivity is probably the highest. So I think it may be related partly to the technique and the poor sensitivity from the nasopharyngeal swab. But generally speaking, from the initial studies which they looked at, once we have a radiological manifestation, as you rightly mentioned, sir, I think it is highly consistent and highly predictive, and very much very sensitive to identify if the patient does have COVID. Actually, if you have the right radiological manifestation. So our idea is that even if it is negative, and if the radiological picture matches and the symptomatology also matches, we usually treat it as a COVID-19. Some of them are willing to get a repeat PCR because, obviously because of the discomfort associated with it. Well, some don't, but in those patients, we still treat them as a COVID-19 patient. And I agree with you, sir, about the fact that there are some of them which come back as negative. But I'm pretty sure, and some centers across Houston, within Houston, not in my institution per se, they do bronchoscopies, and they've had patients who have had negative PCRs. And then they've done bronchoscopies which came back positive. And this is after like 3 negative nasopharyngeal swabs. And me personally, I don't think it's worth the risk, really. But there have been some places where they do it. So, and I think, and I agree with you.
Kumar, on this.
Yes, I think that's a great question. It's a fundamental clinical problem we face because these tests are not perfect by any chance. One, it is dependent on the technique by which you get the nasopharyngeal swab. It is. I had another slide, and I wish I had shown it. The sensitivity of the PCR and the sensitivity of the antibody tests are dependent on the time frame when you get it. So the sensitivity of the PCR drops from the onset of illness, and the sensitivity of the antibody test increases from the onset of illness. So if you are getting there is potentially a scenario where, let's say, your day 12 or day 13 of illness, your sensitivity of PCR has gone down because your viral cultures have gone down, but your antibody sensitivity has gone up. So you could be antibody positive and PCR negative. So one, it depends on the technique by which you obtain the swab. The second is, at what time frame you actually get these tests. So we also, for PUIs who, hands-on look like COVID-19, even if their PCR is negative, they are progressing along just like COVID-19 with all the inflammatory markers. We also get an antibody. And if the antibody is positive, we treat them like COVID-19 anyway. The third scenario that I'll tell you is we had a Vietnamese older gentleman who, again, presented exactly like COVID. The swab was negative. He progressed along and required to be mechanically ventilated. And his nasal swab PCR was checked twice, and that was negative. But the clinical suspicion was so high that once he was on the ventilator, this is very early on, we actually did a bronchoscopy. The bronchoscopy was positive for COVID-19. So the other important information here is that sensitivity of samples you get from bronchoscopy is much, much higher than what you get from nasopharyngeal swab. So the nasopharyngeal swab yield is about 68%, 70%. The yield from bronchoscopy is about 85 to 93%. Now, we are not doing bronchoscopies for everybody simply because it's not risky. So people who are milder illness, people who you think, it looks like COVID, or let's say antibody positive, you treat them as if they have COVID. But once they are really progressing along, and if it's severe, they are intubated, they have a closed circuit so that you can sort of do a bronchoscopy, protecting yourself and people around you. Then sometimes to clinch a diagnosis, we do it for public health reasons as well, because of reasons of reporting. Yeah, so these are the scenarios.
I had one physician, 35-year-old young guy, 106 kg. He came with the classical features, repeated RT-PCR negative. The only thing which saved me is the the antibody test. So antibody tests will probably don't ditch you at the end of the day if you treat them. So I had gone ahead and treated with tocilizumab, all anticoagulation and HFNC and non-invasive ventilation. He did not receive much of NIV, but he received HFNC.
Yeah.
So
the other thing that
probably I did not,
on
just as you, I did not have the courage to go and do a bronchoscopy for the risk of aerosolization and infection. Maybe we'll have more bold studies comparing lower respiratory tract specimen from BAL versus the classical nasopharyngeal and throat swab, and at that point we know probably RT-PCR would fairly good enough for us to make a gold standard.
Yeah, Dr. Fathahudeen, sir, I wanted to add one more thing. Very important is the initial data actually showed that 20 to 25% of COVID-19 patients also had co-infections with other viruses. There was a fair amount of influenza. You could have H1N1. You could also have just the plain old pneumococcal pneumonia. So, there was a trend in the beginning, especially when the pandemic started in the United States, that anybody presenting with pneumonia was getting checked only for COVID-19, and people were forgetting to check for other types of pneumonias which were still around, So we were then looking back, we felt like, oh, why didn't we check for other things? And slowly when you started doing this, you start picking up Legionella pneumonia, pneumococcal pneumonia, influenza pneumonia, all of which are treatable. So that is also other important point, that while you check for COVID-19, please don't forget.
To add to your point, when the initial cases were just trickling in, we did not have enough COVID. At that time, from Ernakulam, we used to send the throat swab and nasopharyngeal swabs to NIV Pune, National Institute of Virology Pune. The early part, I think February first week. I had sent 15 throat swab. I got 7 H1N1 positive patients, H1N1 and COVID negative. But after that, I'll tell you, when the number of cases increased so high that nobody is looking at H1N1, we are getting only the COVID positive or negative. So the standard practice in the initial 2 months, where anyone who's coming with viral picture, but you're not very sure with COVID pneumonia or not, they received oseltamivir upfront, blindly. That this is the one practice which I'm still doing along with azithromycin. Only those patients who are moderate will receive parenteral antibiotics. So 2 more important questions. One is coming from the COVACTA trial did not show any evidence in favor of tocilizumab. So Sujith Cherian also said it, but then this particular agent really work in patients who has shown the typical worsening, isn't it? So your comments, both of you, about the COVACTA trial and tocilizumab.
Go ahead, Sujith.
I mean, if you look at overall, I mean, again, everything basically, if you look at just the mortality benefit per se, or just based on one single index like that, it's hard to basically make a decision just completely on that. And I agree with the fact that, as my personal experience as well, it hasn't shown to be much of a game changer. But like as I said, there are a certain few patients, and I think they're like you said, with the younger patients, perhaps without much comorbidities and who are going into full-blown like HLH kind of a picture or a cytokine release phase. It may be helpful, and I've heard of people who have had success with it. Now, like I said, based on an overall scheme, and this is the problem with all trials, where if you just base your decision on mortality benefit alone, you may miss some of the benefits which may develop. And for example, there are certain patients or certain scenarios where it may help, but if you take it collectively, then the mortality benefit may not be profound or more pronounced. So the idea is all patients behave differently. Like we said, older patients and with more comorbidities have a higher chance of mortality, while the younger patients with less comorbidities may have a lesser of a mortality. And if you take the whole picture per se, it probably may not result in a mortality. It may not result in an overall mortality benefit, but there may be certain scenarios where you could try it, I think. As I said, overall, in my general experience, it hasn't been of a great beneficial, but like I said, 2 of them did survive and they did come out of it. So
survival is important. So probably we should have a large controlled trial, placebo controlled trial. The number needed to treat to save one life. I think for Trustee Sahib it should come. So the last question is a very intriguing question that is coming. That is from myself, as well as some of the people have asked, from the doctors also has asked me. In Kerala and around the world, many asymptomatic positive patients found dead. Okay, they died due to some reason. They are COVID positive. They are asymptomatic. So we know that it's a hypercoagulable state. And is there a chance that these asymptomatic patients even have some amount of low-grade endothelitis going on? Number one, is there any point in giving them aspirin? This is my question. Both of you should answer, Dr. Kumar as well as Dr.
Sure.
Cherian.
So I think it's very hard to.
It's very common in Kerala, and many patients died here.
Right. I think it's very hard to, first of all, say what they died from. It would be nice to know, get some autopsy data and things. There is no argument that there is, an endothelial.
They died while on quarantine. They died while on quarantine for an exclusive disease called COVID, and they were found to be COVID positive. They are confirmed cases, but asymptomatic, kept at home or in the quarantine. Now we have Kerala government has decided to keep all the asymptomatic positives at home. First with the doctors, now with the general public. So now they have to remain at home. So this is the worry that is.
I think it's possible that. Yeah, it's possible that clearly the pathophysiology suggests that they have endothelial inflammation and microthrombi formation and, general hyperinflammatory response. I mean, the way I think about it, the reason why an asymptomatic person would die would be from two things. One, they have a hypercoagulable state and they may have a pulmonary embolism. Or two, there are instances of COVID-19 causing myocarditis, either because of direct viral cytotoxic effect or because of a host response causing a myocarditis or from coronary microthrombi. I don't know particularly about aspirin in general because we don't know if, we know that aspirin is not going, studies that have looked at aspirin for prevention of PE, DVT-PE have not been that conclusive. Obviously it is not a coronary atherosclerotic problem. There are people with coronary atherosclerosis who may be at higher risk of sudden death. For them, perhaps I think it's a very, if it's a low-hanging fruit, such as if aspirin is such a cheap thing to do without much of a side effect, perhaps. But I don't know if we can apply it widespread to everybody who is on quarantine. But these are the two mechanisms which I can think that they would have died from.
Yeah, thank you. So are there any states in the US who are actually prescribing aspirin? Some states in the US prescribing aspirin for asymptomatic positives, at least high-risk population like what Dr. Kumar was telling?
To my knowledge, I don't know of anybody who gives aspirin per se to these patients. But I will tell you one thing.
Don't you think it's a good idea? Don't you think it's a good idea? Like somebody who is 50 plus, hypertensive, coming from a strong family history of coronary artery disease, diabetes, they don't have anything else.
Rightly, all of these patients have a lot of comorbidities, and the risk of illness is higher in these patients with cardiovascular conditions. And this, to my, again, not my personal experience, but within our institution, we have had a couple of patients who have been discharged who came hospitalized, and then they came in with new strokes. And as we said, like Dr. Anupam Kumar said, I think the sudden death could be either from the pulmonary embolism or a sudden cardiovascular death. And
or even myocarditis,
yes. So the idea is, in some of them, they have been discharged and they have come after 2 weeks with new strokes, come within 2 weeks with an acute coronary syndrome as well. So some of us, and again, there is no evidence to back this approach as of now. Some of them, along with the DVT prophylaxis, along with the apixaban or anticoagulation that we do, some internists actually send them on aspirin and continue for around 6 weeks. And this is based on the fact on
6 weeks.
And again, all of us will practice based on our observations, right? Many of them we are influenced by what we see. So some, personally speaking, since I come from since I deal mainly with the ICU setting, getting to that point is less likely. But from the internists and some of them, since they have had patients who come in with new strokes or cardiovascular events, some of them do recommend or do give it again based on their personal experience or anecdotal experience. As of now, I don't know if there is any strong evidence to back this. As we said before, this may be necessary to evaluate in a randomized trial, or maybe it will come out in further observational studies. And so, that's my take on that.
I think with that, I congratulate both Dr. Anupam Kumar and Dr. Cherian for the excellent talk. And this is, as I said in the introduction, it's an evolving disease. We are learning, we are in the learning curve. Every day we learn from our patients, from our patient data. We are not sure. As of now, we don't have a cure. Vaccines probably might come in 1 to 2 years' time without any doubt, I hope. Whether it really confers a lifelong immunity, we do not know. So I take this opportunity to congratulate both of you once again for having interacted with the august audience of Kerala, where we are really facing, this disease which has really devastated the Kerala diaspora, the entire country, and probably the entire nations. And the treatment outcomes are doubtful. Death is going on. So in Kerala, probably we have less than 1% death, but I think that the number of deaths climbing up. I lost 2 patients yesterday and 1 today. Yesterday, 2 patients. So this is gradually creeping. The Kerala death rate also going up. So these are the worries that we have. I think we would interact with more of your upfront experiences, more data coming in, more therapeutics coming in. Probably we will be able to, counter this illness in a big way. And I take this opportunity to thank the IMA Thrissur, Dr. Joy Manjila, and Dr. Unni, who is the convener, Dr. Pawan, and Dr. Abraham Varghese, the IMA State President, and Dr. Gopikumar, IMA Secretary, for having given me this opportunity to listen to this wonderful talk and interact with you. I know that any amount of discussion will not satisfy the audience. This is only a sensitization. Each of us and all of us should go and probably update, see patients. The more number of patients that you see, each patient is an open textbook. Probably we learn, each patient probably will teach you more, a lesson a day. Thank you so much. And now I, hand over the session to the organizers to conclude.
Thank you.
Thank you so much. Pleasure interacting with you all.
Thank you, Dr. Fathahudeen. I mean, it was a wonderful session, wonderful talk by both the faculties and the moderator. And I invite Dr. Unni Baby, our IMS convener, to say a vote of thanks. Please, over to you, Dr. Unni.
Thank you, Joy sir. I directly go into my duty of giving vote of thanks. Let me begin by thanking Dr. Abraham Varghese sir and Dr. Gopikumar sir, State President and Secretary of IMA Kerala, and also to Dr. Jain Chimmen sir, Joint Secretary of IMA Kerala, and other office bearers of IMA Kerala for the wonderful support and encouraging words. I thank this moderator for today, Dr. Fathahudeen sir, for taking the time out from his busy schedule. He's a vice principal, he's a HOD, and he's also an external examiner also. I think he's going to various medical colleges for PG exams right now. So he's in a busy schedule. He has taken time out and came for and conducted this event within a successful and wonderful manner. Thank you so much, sir. And I thank the speakers for the day, Dr. Anupam Kumar and Dr. Sujith Cherian, for the wonderful and insightful talk to this pandemic and the diseases and how they are facing and what we the Kerala diaspora should do. I thank Dr. Arun Krishna for the technical support that he has given. I also thank Dr. Indudharan sir, my chairman of IMA THRISSUR. My personal thanks to our wonderful secretary, Dr. Joy sir, and to our wonderful president, Dr. Joy sir, and to the secretary, Dr. Pawan, for the all the support. And thanks to each and every participant who has come to this talk today. There are almost we had a houseful session. Even at 10 p.m. we are almost having 85 participants, which shows the success of this and the insightful talk that the speakers has given. And thank you each and everyone for the participation. I hand over to Joy sir for the final words. Thank you.
So thank you, Unni, for your kind words. So it went too long, you know. Still, everybody kept in front of the microphone and the camera, and this was a wonderful, session, and I feel proud of everybody because maximum participation. I don't know how to thank you all on my behalf. Special thanks to Dr. Anupam, Kumar, Dr. Sujith, Cherian, and Dr. Fathahudeen for obliging us, taking your valuable time. You know, it's a weekend for you people, and thank you very much. I don't know, that is less. Thank you very much, all the participants, Dr. Indudharan, everybody.
Thank you so much. Thanks, everybody.
Thank you.
Yes, thank you.
Everybody, okay, good night.
Yeah, thank you. Bye-bye.
So the meeting is
Moderator
closed.
did an excellent job. Thank you.
Yeah.
Thank you. Good night.
Thank
Good
you.
night.
Thank you again.
Thank you.
Thank you for the invitation.
Good night and thank you.
Thank you.
The meeting is closed for dinner. At home.
Meeting close it, sir.
Okay,
thank you, sir.
Close it.
Thank you, Joy, Pawan.
Okay.
Yes, sir. Thank you.
Thank you.
Joy, you did it.
Thank you, sir.
Okay, right. Good night.
Night.
Okay,
Good
Bobby.
night.
President, Bobby, bye-bye. Indudharan, sir. Yes. Okay.
Okay.
Pavana kandilla.
Pavan photo. ഗോപിയൊക്കെ പോയി തോന്നുന്നു.
ജോയിനെ കാണാം.
നമ്മളെപ്പോഴും
മതി. ആദ്യം കണ്ടു പിന്നെ കണ്ടില്ല അതാ.
എനിവേ നല്ലൊരു സെഷൻ